Well, hello and good afternoon. It is Friday, November 20th, 2020. It's 2020. Holy cow. Here we are for the COVID weekly roundup. My name's Jason Belden. I'm the Director of Emergency Preparedness with CAF. Almost forgot my title there. And today we've got a few guest speakers with us. Dr. Phil Peters from the California Department of Public Health. Deanne Walters, the Director of Regulatory or Clinical Affairs for CAF. And it's possible that Patty, who's our Director of Regulatory Affairs, may join us in a minute here. So I want to welcome you guys and say thank you. Hopefully everything is going well for you. We've got some updates here, some good, some less than good, but we want to present them all to you. Just as a reminder and an introduction, the speaker's opinions expressed on their own may not reflect CAF's official position. In instances where we offer our personal opinion, we'll try to deviate from what CAF's official position is. These webinars are brought to you from a grant-funded program through the California Department of Public Health. And none of the speakers, well, I'll say that Deanne and I have no financial conflicts, and I assume that Dr. Peters does not have any financial conflicts either, but I'm not certain about that. And the intent of the webinars is to essentially give you a situational report of what we understand the regulatory environment around COVID is, what we forecast for the coming week, and best practices that you could implement to help you meet those requirements. So with that, we're going to hop into a presentation on monoclonal antibodies, and Dr. Phil Peters from CDPH is going to present some information for you. What I want you to do, since we want to be cognizant of Dr. Peters' time, if you have questions specific to monoclonal antibodies, please take a minute to pop those into the question and answer box. And while Dr. Peters presents, we'll read through the questions and try to present them to him after he speaks. So, Dr. Peters, I want to say thank you greatly for taking some time out to spend with us to explain this, the monoclonal antibodies. Please take it away, Dr. Peters, and we'll get to questions at the end if there are any, okay?
Great, thank you, Jason. Thank you, everybody, for joining us here. It's really a pleasure to be able to talk with you. So as was mentioned, this presentation is going to talk about one particular monoclonal antibody, the one that so far has received an emergency use authorization. It's going by the name of bamlanivimab. It seems like people are kind of calling it BAM as sort of for short, and we're going to review a little bit about the product and how initially it's been allocated within California, and wanted to kind of preview with you some of our thoughts for the phase 2 of the allocation. Thank you for mentioning financial interest. I don't have any financial conflicts with this medication or other financial conflicts. And some of these slides are actually taken from the Operation Warp Speed presentation. Operation Warp Speed is the federal program that's coordinating a lot of the federal purchase of these investigational agents, as well as the vaccines. So you hear about it more with regards to vaccines, but they're also helping to support development of some of these investigational treatment products. So some of these slides, especially the ones that have kind of this blue arrow on the side, are taken from their presentation, and that is those are available online as well. But this is kind of the big picture overview slide. Monoclonal antibodies directly neutralize the SARS-CoV-2 virus, the virus that causes COVID-19, and they basically bind to the virus so that it can't enter our cells. And so if used to treat somebody early in illness, the theory is that it can prevent progression to more severe disease because it's kind of halting the viral replication at an early stage. So they're thought to be most effective when given early and are probably not effective at all once somebody has developed more severe illness and is developed a severe illness where they've required going to the ICU. The product is delivered as just a single IV infusion, so it's just a one-time dose. The antibody sticks around in your body, these particular antibodies, for about 4 to 8 weeks. So 1 to 2 months, the antibody will be in your body. And the reason it got an EUA, an emergency use authorization, is that in the one trial that's been published so far called Blaze 1, in that trial, they showed that there was a reduction in the number of people who were hospitalized when they were given this product early. And I'll review those trial data in a little more detail. We can move to the next slide. So this is kind of what the data looked like. There's 2 trials on here. One's been published, one's only a press release so far. But the Blaze 1 trial is really what the EUA is based on. They had 465 non-hospitalized adults with mild to moderate COVID-19. And their primary outcome was actually looking at the decrease in viral load in patients who got the product compared with patients who got placebo. And they saw a little bit, that's represented on that figure on the right, and they saw a little bit of a reduction in the viral load. But what was interesting was their secondary analysis, that overall among all patients who got bamlanivimab, 1.6% needed hospitalization or an ER visit subsequently in their illness versus 6.3% in placebo. And when they stratified into 2 groups that we know are very high risk for severe COVID illness, age greater than or equal to 65, or body mass index greater than or equal to 35, almost all the adverse outcomes occurred in people who met those criteria. And the reduction was from 4.2% who required a hospitalization or ER visit to from 14.6% in people who received placebo. So it's that reduction in subsequent hospitalization is what drove the approval. A parallel trial, a cousin trial, you might say, called Active 3, was done in people whose illness was severe enough that they already required hospitalization. So more severe illness and also likely farther along in their illness. This trial was discontinued because there was no evidence of clinical benefit in that population. So it seemed like it provided benefit in non-hospitalized patients with mild to moderate illness, but not in hospitalized patients with severe illness. Next slide. And so the clinical indications, this is kind of them at a high level, and I like to think of the clinical indications in 4 different categories. One, you need to have somebody who's got mild to moderate outpatient illness. So they're not hospitalized, but they do have symptoms. So to reiterate, this treatment's not for people who are asymptomatic, even if they have high risk factors, and it's not for people who have already required hospitalization. The second indicator is that it's indicated for people who have a high risk of potentially developing severe illness. And so I've bolded the 2 groups that in the clinical trial really came out as seeming to benefit the most from this treatment. But some of the other criteria that are in the EUA are chronic kidney disease, diabetes, and immune suppression. And the EUA is actually broader than what was studied in the clinical trial. So there are some additional criteria for people over 55 and some criteria for adolescents in the 12 to 17-year-olds group. The third clinical feature is that you need to treat early. So in the clinical trial, they were treating on average 4 days from symptom onset. So from if the clock starts once you develop your first symptoms, the average person in that trial was getting infused 4 days after their symptoms started. So the EUA gives you up to 10 days, but most people think that that's too long. And so it really needs to be provided early to get that clinical benefit. And then the fourth is that it's an IV infusion. So it has to be administered in that right patient population and early in a setting that can do an IV infusion. And so that is, it's not like an IV infusion, like trying to infuse blood, but it is a monoclonal antibody. And so they did have, in the study, they had 2.3% of people who received the monoclonal antibody product had mild infusion reactions. These were, I think it was 7 total patients. They were able to get the full dose of the medication, so they didn't have to stop the medication, but most of them were given antihistamines. So manageable, but you obviously need a nurse or other clinician who's able to evaluate those reactions to make sure they're mild. And the concern is the risk for anaphylaxis, which we don't know how common that, or we know it's going to be a rare reaction, but we don't know how rare. Is it going to be 1 in every 300 people has an anaphylactic reaction, 1 in 1,000? We assume that there is a possibility of anaphylaxis just because with other monoclonal products, anaphylaxis has been observed, rarely, but it has been observed. So the clinical site who's doing the infusion should also have access to epinephrine and a mechanism that they could call EMS if they detect an anaphylactic reaction happening. And for that reason, clinicians who are infusing this are required to report any serious adverse events, as well as any deaths that occur that are related to infusion of the medication. Because again, the clinical trial only had 450 people, so that's not a large number of people that it's been studied in to date. This is a big picture of the federal allocation process. This product, as I stated before, has all been purchased by the federal government. So the actual medication is given to us for free. There's no cost to the patient or to the state or to the healthcare facility for the medication. The federal government will tell us what our state allocation is based on how many cases of COVID we're having compared with other states in the country. We then report back to them where we want all of those doses to be shipped to, and then a company called Amerisource Bergen will fulfill those orders and ship those amounts that we've specified to the pharmacies of the facilities that we've specified. So there are 2 phases of the allocation. We are right now in phase 1, and in this phase, all of the bamlanivimab is being sent to hospitals and hospital-affiliated locations. Now, this is a little counterintuitive because it's an outpatient medication, so it has to be given in hospital outpatient locations like ERs or urgent cares or infusion centers that are being set up. But the reason this was selected is because there was a distribution process already in place to send product to all of these hospitals because of the previous EUA product, the remdesivir, that had been distributed to all these hospitals. However, recognizing that that might not be the ideal place for all of the product to go, phase 2, which will hopefully start in the next few weeks, allows states to allocate to outpatient facilities. And skilled nursing facilities, I think, as you will see in a little bit, I think are really at the top of the list there for ideal locations to provide this product, if logistically that can happen. Other options would be non-hospital urgent care and outpatient offices, home health services, especially through the PACE program is something I think that could offer a lot of benefit. And then there already are plans in place to develop some community sites that would be probably temporary tents that are outside, similar to outdoor locations where people are getting testing, where they would get the infusion. Reason being is that this product is you have to identify somebody early and give the product to them early. The early phase is also when people have the maximum infectiousness. So anything that's can be anything where you're not bringing somebody into a new setting. So either they're already in the setting, like at a skilled nursing facility, or they're coming to an outdoor setting might be preferable. Okay, next slide. This is so far what we've received in California. We received about 4,000 doses the first week. Most of those have now arrived have been distributed to the respective hospitals. And for week 2, we found out we have received a little over 2,000 doses. The federal allocation decreased by about 50% from week 1 to week 2. We're in cases in California have gone up, so we've gotten proportionally a little more than we received in week 1, actually, even though the number's a little lower. We're hoping that the federal government will kind of keep the distribution relatively steady, so we don't have sudden surges or droughts in supply for these sites that are being set up. And right now for the allocation to acute care hospitals is being done based on the 7-day hospitalizations in COVID confirmed patients by county. So that metric is being used for the allocations for the hospital phase because the hospitalizations are what we're trying to prevent. So that gives a surrogate marker for the burden of infection within different communities. We're considering bringing in another metric to look at community cases by county also, so to kind of weight the allocation for hospitalizations and community cases when we move to phase 2, as we'll be engaging with more community facilities. In that, when we're posting both the details of the allocation on it's one of the documents on that website there. It's under the latest guidance, sort of at the top of that web page. But also at the very bottom of that web page, there's an Excel file that shows you exactly which hospitals have received or which facilities have received the allocations to date. And next slide. So this slide is supposed to be an acknowledgement slide that went through a lot there. Maybe it might have seemed like I was saying it was going to be easy to do, but it's not. I think we all recognize that it's not easy to do. This medication is limited in supply. There's not a lot of it. You need appropriate healthcare staff to be able to infuse it. There needs to be training both on the product and on how to infuse it. And there's just preparation and logistical time that has to be put in to prepare to be able to administer this product. So this is to, acknowledge that there are a number of barriers. Next slide. This slide is another Operation Warp Speed slide, but I think it really gets at why skilled nursing facilities might be good locations to do this treatment if we can. One is that the treatment's most beneficial in patients if given early in symptom progression. So you want people who are being tested frequently so that they're going to be diagnosed relatively early in their illness. Typical people in the community are not getting tested very frequently. They will usually only come in to get tested if their symptoms are kind of escalating and getting worse. So their symptoms could have gone on for a few days before they get tested. Compared with skilled nursing facilities where people are tested a lot more frequently, and just given that the probabilities, you're more likely to find people early in their illness course. The treatment needs to be given as soon as possible. I'm sorry, I'm going to back up to the first sentence. It's treatment likely most beneficial. It doesn't say this, but there are certain risk factors that it's going to be most beneficial in. And, for better or worse, what really is holding out as the best risk factor is age. And so that's kind of a straightforward risk factor, and also encompasses the vast majority of people who are residents in SNF facilities. With increasing age, 70 being worse than 65 and 80 being worse than 70. So increasing age is increasing risk for severe illness. I'll also point out that the treatment has to happen as soon as possible. So having a situation where the diagnosis is happening at the same place where treatment could happen, that cuts down on hours, if not days, of time to get somebody from getting their test result back to actually going to another site to get an infusion. And then finally, there is the testing part. You want situations where the testing turnaround is quick. So I will just point out that positive antigen tests in a symptomatic person are sufficient documentation for treatment. And we could move to the next slide. So I think this is my last one, but this is, again, acknowledging that there are a lot of boxes that would need to be checked to set up the capacity to administer this medication really in any setting. But I think this goes through it kind of nicely, that there needs to be a dedicated area where the infusions would take place, kind of a clinical site. The supplies and resources would need to be located in that facility. The proper personnel need to be involved. Most importantly would be the nurse or IV tech who's running the infusion. So that by far, that's going to be the most important piece. But you also need the physician or other ordering healthcare provider to make the decision to do the treatment. So you get the positive test, communicate with the healthcare provider. Any prescribing healthcare provider can order the medication. And then another important piece is the pharmacist, that it is something that is stored in refrigeration, and then it's prepared with normal saline. So you're going to need a pharmacist and who can prepare the infusion and then send it to the facility to do the infusion. And I'll mention one more part is the reimbursement. So I've sort of been talking about that the drug is free, but there are all these other costs, some easily apparent and some less easily apparent, that need to be taken into account. So CMS has put out coding where you can code for these infusions and get reimbursed through CMS and what we are assuming through other insurance, Medicaid, Medi-Cal, and other insurances for providing this. But of course, that's a new process, and there's, I'm sure there are things to work out with that reimbursement. And maybe the most difficult part, I think, is that the pharmacy clearly has a role in this, and it's not clear how the pharmacy would be reimbursed for what they're doing. It might, and I actually believe it might be a situation where we're just asking pharmacies in this emergency situation to do the preparation of the medication without reimbursement through this program. But again, I'd love to hear your questions, and this is obviously a work in progress that we were trying to do continuous quality improvement to make it better as it goes along. So I think I'm learning along the way with everybody else, and we hope that we can come up with a process where we can provide access to this medication to people who may benefit from it more than your general public person with a new COVID infection.
Well,
next slide. I think that ends it. Yep.
Yeah, was that it? Okay.
That is it. Yeah.
Well, thank you very much, Dr. Peters. We have one fairly detailed question here, and I'll try to answer this because I'm not sure where this is going. So, Eli Lilly is continuing to conduct clinical trials and is including SNFs to participate. Is that still continuing? Are they still looking for SNFs to participate in clinical trials, or is that done?
Yes, I believe they are. So if there's this was the Blaze 1 trial that was published. There's another trial called Blaze 2, which is being done exclusively in skilled nursing facilities, skilled nursing facilities. And there are two other companies, although I don't think they have protocols that are exclusively in skilled nursing facilities, but I could be wrong. One company is called Regeneron and one company is called AstraZeneca. So both of them also have monoclonal products that are fairly far along. My understanding of the Lilly trials is that this medication that got the EUA is a single monoclonal antibody, meaning that it targets one particular part of the virus. What they're continuing to study in their clinical trials is a product that is two monoclonal antibodies combined together. So it's this monoclonal and another one that just targets a slightly different part of the virus. And they're hoping that having two sites of where it neutralizes the virus will be more beneficial than even what they've seen with the one site neutralizing.
Well, that's good news. We're rooting for that to happen for sure. So maybe this is a question for Deanne, but it does have to do with how we give this medication. And somebody asked, where can we get the training necessary for RNs on IV infusion since it's a new medication? And so one question, my question is this something that could be in-serviced and brought in quickly, or is this something that's going to require more training than just a few minutes?
This is Dee, and I'll just jump in. Well, you know, when we have the process in place to get the medication out to the pharmacies for skilled nursing, along with it, just like anything else, there will be guidance and direction on, you know, what skill and training you're going to need, what is the equipment that you will be utilizing to provide the treatment. And at that point in time, you will be able to do the upskilling for your nursing staff to ensure that this medication is within their ability to provide. So it is treated like an IV. So any of your nurses that are your RNs can start the IV, but of course we will want to ensure that they have all of the information on this one and any reactions that they're going to be monitoring for, and that will all come out when we start receiving access to the antibody treatment.
Awesome, thank you. So I want to just reiterate and say thank you, Dr. Peters. I want to be cognizant of your time. I don't think we have any other questions as it relates to the monoclonal antibodies, but if I get anything, Deanne obviously will connect with you, and then we can clear that up offline for folks if they have questions. So, and he says, one more question. When is phase 2 allocation set to begin, or do they know?
There's not a timeline that's been publicized for when that will happen, so I'm a little in the dark about that as well. I actually think in California we'll probably have a slow migration into phase 2. So even as early as next week or the following week, we might start providing allocations to outpatient settings. And I will run that by the federal government. I don't think they're going to have a problem with us moving to it a little earlier. But I think we're also recognizing that every setting that we would ideally like to do this in the outpatient arena is not going to be ready at the same time. So it's probably going to be a process of bringing along settings that we've kind of identified as being optimal for this treatment, bringing them on once they're ready to start receiving product. The thought process with the skilled nursing facilities was that the product would go to the contracting pharmacies, because the pharmacy would need to still prepare the medication before it was infused. That's the current thinking, that would make a lot more, that would make more sense than trying to prepare the product on site. And then the contracting pharmacy, after it's been prepared, you have 7 hours at room temperature and longer if you're refrigerating the product, I think 24 hours. So it can be, that I think gives enough time for the product to be prepared and then sent to the facility that's going to do the infusion.
Well, thanks, Dr. Peters. That answered the question, and that gives me a segue into some of our later conversations in the webinar. Thank you very much, Dr. Peters. I appreciate it. You're more than welcome to hang out with us if you want, but don't feel the need to listen to us explain AFLs if you don't want to.
Thank you, everybody. Appreciate it.
Yeah, thank you.
Good
All right,
night.
guys. So I do know that it's possible that you're going to start to see surveys come from your local jurisdiction. I know in Sacramento County, the MOAC has sent out a survey to ask people what their capacity is to do infusions. And if you're wondering, oh, okay, well, now you put 2 and 2 together, why you're getting asked those questions. And if you answer, the reason being is they're looking for capacity and who can do these infusions. All right, I want to hop to the AFLs and the latest updates. There was a big one that dropped earlier this week. It's AFL 2086. It has to do with the going home for the holidays, essentially. There's a link to the AFL. What I did is I took out portions of the AFL, and we're going to discuss each one of these, but this first bullet point with the 4, or the bullet point with the 4 links underneath it, it's important to note that when you think about developing a packet, we're going to talk about what should go into this and what you should be talking about with your residents and families if they decide to go home. But if they do, you're going to have to develop this pack of information. And it's going to include all of these things that CDPH wants you to provide to the resident and their family to help inform their decision making about whether this is the right decision for them to go home for the holidays. All right, so when we counsel those folks, CDPH has been pretty clear that this should be allowed, but there are considerations to make when we do this. And there are things that we should counsel the people and their families that when they leave, if they choose to do it, that they should kind of follow this structure. And most of it is stuff that we're doing in our facilities already, and we want to encourage them to do it. But I did carve out some general information. So the COVID cases in your community, I'm going to get to the testing thing, but the best, what everybody's trying to do, or what CDPH is trying to get you to do, is to use this blueprint for a safer economy as the source that you use for the visitation and the testing, and they're trying to align all this with that data source. And so that means the CMS data, we're not going to use that, and I'll talk about that in a second. But that's going to stay consistent, hopefully, for the remainder of the response. And so we want to incorporate that into all the things we do when it tie into the positivity rate in our county. So we're going to encourage folks that when they go home, they're going to have outdoor visits if possible. Obviously, if it's 50 degrees and it's raining, that's not going to be maybe appropriate to have grandma outside all day long for that. And so we've got to think about, if we're doing indoor spaces, counsel them how we do our indoor spaces and how we try to protect ourselves indoors. We want to encourage the duration of the gatherings to be shorter in nature. And this this bullet point on the number of people at the gathering, and I believe this is the recommendation for for everybody else. It's that you should have a maximum of 3 households in your home gathering or the gathering that you're going to attend. You should pay careful attention to the location that the attendees are traveling from. So me being from Sacramento County, knowing that we're experiencing the most significant surge within our county since the beginning, if I travel to another county, there's risk for me at the other county. Consequently, if somebody comes from a county that has a high positivity rate, it's going to increase my risk as well. I think one of the things that we've learned, and I'm going to show you some data in a second here, that pretty clearly identifies that the trend line of positive cases in skilled nursing facilities is almost lockstep with the positivity rates in the community in which the facility resides. And it's not unique to us. It's happened everywhere, and it happens with real regularity. It's something that we can really put our hats on, because we don't have any examples where we have uncontained community spread and skilled nursing facilities aren't impacted. So we know that's a direct barometer into what the risk level is going to be for our employees to bring it into our facility. We need to encourage the behaviors of attendees prior to and during the gathering. And I know folks, as soon as they get out the door, they're going to hug and love on their family member and all that things. We can't, belittle folks or make them feel bad that they want to touch their loved one. But what we have to do is almost like a form of harm reduction and say, look, if you absolutely break these rules, don't just say, well, you know what, I made a mistake, let's just take the mask off, or let's just, it was just one little mistake. Hey, if you realize that your mask is off or your mask is slipped or you're crowding in somebody's space, it's okay to take a step back and readjust and say, I made a mistake before, but let's go back to what we're doing. I don't want to get to the thing where people just say, heck with it, we're going to roll the dice. And we want to discourage our families from doing that, even if they don't have the same kind of seriousness around COVID that we do. During the holiday gatherings, and this is all of us. This is in the AFL, but it's all of us. If you become sick prior to the holiday, don't force it. This goes for all of us. Encourage social distancing if we can, at least 6 feet apart. Wear face masks, clean hands off, and all the things that we do in our facility already. People, including the residents, this is the one that I thought was kind of funny, in that, it says including residents should not attend. Well, if we shouldn't attend these things, well, gosh, why did you issue an AFL that says we should, or that we are going to attend? But the first 4 bullet points here are very important. If somebody's diagnosed with COVID-19, they have symptoms of COVID-19, they're awaiting results after an exposure, or you've known they've been exposed to somebody within the last 14 days, those folks should not go. And frankly, their family members should want to protect themselves too. Everybody in our building is at increased risk of severe illness for COVID-19. So I'm not sure why they added that bullet point in, but definitely know that, if you think about it in terms of cohorts, your yellow and red folks are not going to meet this criteria. All right, recommendations for facilities. So this is going to apply to everybody, not just folks that are going home for the holidays. You may hold holiday activities as long as you maintain strict adherence to core principles. Residents who are not on isolation may eat in the same room with social distancing. So that's the green zone, folks. Group activities may also be facilitated. We want to make sure the use of face covering is encouraged, and for those that will tolerate it, we want to make sure they have that on there. I realize that the face coverings maybe you should realize and should understand the face coverings are not an elimination strategy. They're a mitigation strategy. And in the aggregate, use of masks lower the rate of transmission and death, but it does not necessarily give you 100% protection. It is a mitigation strategy to try to reduce the amount of spread and slow it down. And a lot of times we've got to this point where we think masks are the end all be all, and they're not infallible. So encourage as many of these activities to occur outdoors. Once again, the weather has changed pretty dramatically in Northern California. I think Southern California might be a little more temperate, but if you can do activities outdoors, by all means, we want to encourage that wherever possible. And facility communal holiday activities and dining may not include visitors. That's a real important one. So we can have the holiday activities and the dining stuff, but we just can't have folks from the outside come in and participate in those. Returning residents. So for those folks that do go home, we're going to test and isolate those symptoms, immediately test the residents upon return, and then isolate any symptomatic residents in a single room pending the results. We're going to quarantine residents returning to the SNF for in settings with communities in substantial or widespread transmission. And so that's the red or purple categories. And I know this is super confusing because this is the, there's multiple AFLs that tie into, this data. Some of them refer to colors, some of them refer to these terms like substantial and widespread, and some of them, like the ones from CMS, come with a set, kind of analytical line, and anything below X%, you do one thing, anything above. These things are not set up for that exact thing. So for this particular thing, you want to look at, is your community in a substantial or widespread transmission? So red or purple, and if they are, that resident, when they come back, goes into that quarantine and they stay there for 14 days, and we're going to test them at the end of the 14 days before we bring them out. All right, I want to just have I'll try to get to this as quickly as possible so we can get to the questions. But we've had a number of conversations with CDPH about fit testing, and they're a repeat of conversations that we had back in April with the director of Cal OSHA as well as Heidi. And we told them, we were very frank, and we told them there were probably 80,000 people that worked in skilled nursing facilities that had not gone through the initial fit testing process. And that was a gross estimation on my part, and it could have been 20,000 less than that. My point was that the need was substantial, and we had no ability to meet that need. And knowing that we cannot fit test these people, we don't have the resources to be able to do it. We don't have a selections of masks to be able to even meet the intent of the fit testing. I understand that. We understand that. We've explained that ad nauseum to the very top of the food chain over at those programs. And all I can do is keep saying, these are unrealistic expectations that you have. What you have to do in terms of protecting yourself and you going forward is you have to document all your efforts to obtain everything within that kind of fit testing element. If you had already done fit testing and you had like 3M and all your masks were 3M that you had, and you can no longer obtain those masks, you document your efforts to do that. So that's one, you're protecting yourself. You're saying, these folks, I went through the process to get them initially fit tested, but I can no longer obtain the masks in which they were originally fit tested for. So that's number one. We're going to protect ourselves and make sure that we have those efforts. The second thing is, whatever masks that we get, we want to try to have our staff be able to make a seal on those masks. If they can't make a seal on the mask, becomes less reliable. Now, I'm not going to say you are automatically going to get COVID if you have a break in the seal in the mask. I don't think it works that way, but it certainly increases the risk dramatically of you being exposed. And so, you know, we want to take care of our staff just like we take care of our residents. Without the staff, we don't have residents, and without the residents, you know, we don't have a business. So it's important that we make sure our first responders, the folks that we have, do the best that they can. Now, everybody just inundated me like, hey, that's all fine and dandy, but the masks I get, I can't even get a seal check or a seal on half of them. They're poorly made or poorly constructed. Things like that. I understand all that. You're going to have to document those things. I brought this up to those folks on the call yesterday, and I was, because I don't have an answer for you guys, and I don't think they do either. And it's completely unrealistic to put all of this on you when you spent hundreds and hundreds of hours trying to source the correct PPE. It's really hard, and I just have to really coach those folks up, and then hopefully they can bring some resources to bear in terms of not just the fit testing equipment and the hoods and the Bittrex solution and all that to get the fit test, but to get us a source of PPE that meets different face sizes, that has some consistency in its performance. And we'll continue to push for that. And in cases where we cannot get that, we're going to make them aware of the fact that this is a fight that we've thrown everything at, and we're asking for help and we're not getting it. And so that's our focus and our push with these folks. And I think it could, we could have some success in being able to, well, we've definitely put this on the radar of the folks from Cal OSHA. We've asked for proactive help in education, hands-on, classes for fit testing, even if it meant their survey staff went out and helped fit test us. We've asked for everything, guys, and the cupboard is bare, and I apologize for that. If I had a better solution for you, I'd give it to you. So I would prepare for oversight, and that's why we make sure that we maintain all of those records of our efforts to source PPE. All right, so let's hop to the testing before we get to questions. This is important. So we've talked to CDPH, and I think Heidi clarified this, but for those of you that either A, did not have a chance to tune into those, or B, you didn't understand what Heidi said. In terms of the testing and how often we test, this is the answer today, and we know this could change, obviously, but anybody that's over 10%, not tied to the color of your county, your county color could be purple, and you could have a 3.2% positivity rate. So you have to, on that website, if you go to the Safer Economy website, scroll down till you see the California map, highlight and click on the county in which your facility is in. It will tell you with a little bubble that pops up the percentage or the percentage rate, test percentage rate of the county. If it's not over 10%, you're not required to test twice a week. If it is over 10%, on the day that you check your thing, then for the next 2 weeks, you're going to do testing at twice a week. And CDPH is going to clarify that in an AFL. We expect that AFL to come out pretty quickly. They've said that there's a data disparity between what CMS uses and what they collect on that website. And in their estimation, they feel that is more accurate, so they want you to use that. And if at any point the CMS data becomes more reliable, then they may move back to that. But for the time being, we're going to use the COVID-19.ca.gov Safer Economy to determine our testing frequency. If you put in your mitigation plan that you were going to check the CDC data or the CMS data, remove that that section and just put in this website, and that's going to be the website that you're going to use. So when do you check? You're going to pick an arbitrary date every 2 weeks. I'm not certain the AFL is going to be specific to which day you have to check it on. Think about operationally what day is the easiest for you to switch whatever your operations are going to be. And so maybe that's on a, every other Monday or something like that. But that's up to you to determine, and you want to adjust that in your mitigation plan. All right. I told you I was going to mention some other stuff, some good news and maybe some not so good news. I talked about the rate of community spread being tied to the spread in nursing homes. And this is just a list of outbreaks in the 4 largest states, because we like to compare ourselves in population and size and number of facilities to these other states. And if you look at this in terms of the positivity rate, California's line looks less dramatic. There's less peaks and valleys within it. And but it does show that trend line matches the trend line of the community or of our state during those same times. And for each one of those other states, that trend line matches what happened in those states at that time. And so if you can see the one that starts really high and drops way down, that's New York. And New York was hit first and hard, and then it dropped off the map. And then we were hit. And we went up and we flattened the curve, and then we had a July spike right after 4th of July. And now we're having another spike 2 weeks after Halloween. And so you kind of get this idea that people gather, 2 weeks later, community spread goes up. And that's just the way it works. If you have a highly infectious airborne virus in indoor environments, people are going to get sick. That's just the bottom line. All right, here's the good news, guys. Dr. Peters comes on and talks about studies, or talks about services that we can do to help reduce the mortality rates of folks with in our facilities. We are doing an extraordinary job. You are doing an extraordinary job. People that get sick in our buildings are dying at a significantly less rate than they are in other parts of the country, especially as compared to other large states. So that is solely due to the hard work that you guys have done each and every day since this has begun. So give yourself a big pat on the back. Our work is not done yet. We need to work hard each and every day to make sure that that number stays where it's at. And we use every available resource to protect the folks in our building. But this is great news, folks, and it also is a kind of an indicator that all of the work and all of the hard work that you guys have done has really, really made a difference. And we had a conference where our national president from former governor of Kansas, who spoke to us, who talked about the experience that he gets to see from 30,000 feet to all states. And he was effusive of his praise of the performance of the nursing homes in California. And I would just, for you guys that were not available to see that, I just want to say thank you from the bottom of my heart. I know Deanne would definitely back me up on that. But this is all due to your guys' hard work, so thank you. All right, I'm going to try to get through a few questions here before we get out of here. And just as a reminder, guys, next week we're not going to have a webinar, and sadly, the Wednesday and Thursday calls are going to, for CDPH, are not going to occur either. So in terms of maintaining situational awareness for the next week, my suggestion is, one, if you have questions, use us as a tool, use CAF as a tool. We're a tool in your toolbox to get situational awareness, but never hesitate to reach out to these folks. I know they've been much better about being collaborative and helping people get through it. So if you have individual questions, don't wait 2 weeks to get your answer. Please let us know right away. All right, I'm gonna try to get through this here. All right. best practice. To whom should the IPC nurse report to? The administrator or the DON? Deanna, are you still on the call with us?
I am here. So yeah, that's a great question. And I know that the question is asked about the MDS coordinator and the DSD sometimes. Really, there isn't one right answer. It's really going to be based on what works best in your facility. I can see how an IP might directly report to the director of nurses, both being nurses and speaking more of the same language. But I also know that there are very involved administrators that like to be able to delve into the clinical side of things in order to ensure that they have a picture of everything that's going on. So there isn't one right way. It's going to be what works best in your facility to ensure that the information is going from the infection prevention control coordinator to the right people in order to get it out. If your director of nurses is handling, say, an outbreak and things are really crazy, then it might be best to have that person really communicating to the administrator who might have the time to then adjust and work with that person while the director of nurses is otherwise occupied. So really it's going to be situational, and it will be, based on the needs in the facility. So, have a good conversation with the leadership team to see what's going to work best at your facility to ensure that you have the best communication and response.
Awesome, thanks. I'm glad I asked you. I'm thank you for answering that. That was great. So next question is, where do you suggest to document all efforts related to fit testing? In the mitigation plan or through QA committee, agenda items? Well, each one of you guys is going to be running your quote unquote incident command a little bit different. I teach folks that we need to have logistics in our command structure. And so that should be somebody's duties. We should have procedures or tasks written out for these folks, and maybe some kind of form to capture the information by vendor, who they're calling, when they're calling, and what the results of those calls are. It doesn't have to be, we don't have to overkill these things, but we do have to document the times and the dates and where we're searching for those things. And for many of us who have gone through the process of requesting resources through the MOOC, whatever you do to kind of access those community resources, whether it's you get denied or whether you get approved and the approval comes with masks that are different sizes than you asked for or different brands than you asked for, we understand that. You just keep a copy of those records. I don't know that I would necessarily put them in the mitigation plan. I would keep them in kind of your filing structure that your folks in your administrative section of your command are putting together and gathering that information. I think it's important that you have that at hand, because I do suspect that very soon surveyors this is going to, a part of your infection control survey is they're going to be asking for proof that you've done this fit testing. And when you say, well, I haven't got everybody fit tested, or I've got 50% fit tested, the next question is going to be, okay, show me the efforts that you made to obtain the material and the appropriate mass. Hopefully that answered the question. All right. Oh, there's another one. When documenting our attempts to source a product, what documents do I need and should I keep as proof? Okay, I think I answered most of that. There's no specific thing that's going to be your e-ticket to get you out of a deficiency. I think it's going to have to be a totality and a demonstration of your effort. I know many of you guys have called manufacturers and tried to develop relationships with actual supply or with actual manufacturers that make the product all the way in China, and you've created these new relationships with these manufacturers. All of that stuff can be used to kind of build your protection on the back end. All of those efforts are going to help if you get sued at the end, to be honest with you. That's really what we want to protect you from. So,
and even something as simple as like a paper log of all the calls you've made, the numbers you've made them to, and if you were able to speak to someone. It doesn't have to be really super technical. If you have an easy way to save files, you could even snap a screenshot of your phone for the phone numbers that you've called out to and save that. So there's a lot of different ways. So like they say, not one way, but it can be very simple. It could be a paper log or a computer Excel log of all the calls you've made, when you've made them, the numbers you've made them to, and a small generic thing about what you actually talked to them about. So you don't need to overcomplicate it. Just get it down somewhere and have it saved, not where we always think is super important, we'll remember because then we forget, but somewhere where it's easy to find even if you're not in the building.
Yeah, perfect. And I've got one last question before I wish you guys happy holidays here. I had a question about this. So there's a question here that says, if a resident goes out on a pass for Thanksgiving, does the facility need to test a resident automatically, even if they, well, I think this means even if they are not symptomatic? And do we test a resident when the resident comes back from to the facility? It's my understanding that yes, you're going to test that person when they come back to the facility, regardless of whether they're symptomatic. I almost thought that was a typo when I saw it. And then it goes on to say that in those two counties, the moderate and widespread counties, you would test on the day they come back, and you put them in quarantine, and at the 14th day in order to get them out of the quarantine section. That's the way I read it. I could be wrong, but I don't think I am. I just think it's the way they phrased it is confusing, and it makes it like, oh gosh, does it mean that I only test if they're symptomatic, or do I test automatically? And I think I would test automatically. Just, this is me, my personal opinion, not following the AFL. The problem is that test, if that person got COVID or was exposed to COVID, that test on the first day is not going to capture their positivity. That test on the first day would capture it if they got it probably before they even went home for their visit. But even still, as out of an abundance of caution, that's what I would recommend, especially if you already have that capacity built in. If you have your testing coming that day, everything could align. So, all right, I'm going to get to the end, and I included a couple of handouts that we've handed out before. Please take some time, feel free to look through those. Thank you very much, guys. Have a great holiday, wonderful Thanksgiving. Thanks, Deanne. Dr. Peters is gone. Thanks, Jamie, for being such a gracious host for us. And I want to wish you guys a safe and happy Thanksgiving. Hopefully, when we talk again in 2 weeks, we won't be talking about large community spread, and hopefully we'll be talking about distribution of a vaccine. And so we've got that to look forward to in December. Take care, guys. Have a great weekend. Bye-bye.
Happy Thanksgiving.